A very good afternoon to all of you. At the very beginning, my sincere thanks to the National ISA for organizing this webinar on a very pertinent topic. This topic should not be just for the layman or for the general public, but now it is a time that this topic should be in every teaching center, in every teaching hospital, and this is the time that we need to develop centers which should be specialized in organ retrieval. As far as the ICU management of potential organ brain dead donors are concerned, there's nothing much different as you manage any critical ill patient. There are just a few differences which I would like to highlight in the topic. If you look at the statistics, in India, the diseased donor organ donation rate is only 0.8 per million. And if you compare it with USA, UK or Spain, we are at a very dismal rate. It's very low. Now what are the reasons behind it? One is early identification of the potential donors. The adequate donor management. Once you have declared any patient as brain dead, are we doing the correct management of that? And even if you are able to retrieve and survive, make that patient ready for organ donation, is the quality of the organ optimal or not? So that is another question. And many literature has suggested that even if the organs have been retrieved from a brain dead patient, and when they have been subjected to transplant, the quality of the organs were dismally poor. Protection and optimization of the organ functions, that forms the core of the critical care for such patients. Now there is a window period when the intensivists are involved, and that window period is the time frame between the brain death diagnosis and the referral to the operating room. The key role is to apply interventions which are not only some general interventions which you do for all the patients, but there are some specific interventions which can increase the chance of successful transplantation. And one thing has to be always kept in mind, that when you are caring for a potential brain dead organ donor, you are caring for multiple recipients. So that gives a lot of satisfaction to the intensivist. Now if you go into the management guidelines, in the recent Journal of Intensive Care Medicine in the last few months, this journal has just concentrated on organ death, or brain death and organ retrieval. Last few articles, last few journals, last few months, they have just concentrated on this aspect. And I will be basing my talk on this review article published in Intensive Care Medicine. There are other guidelines which have come from the Society of Critical Care Medicine, the American College of Chest Physicians, and Association of Organ Procurement Organization consensus statement. This was done in 2015. And then there are some guidelines for management of potential organ donors from the Indian Society of Critical Care Medicine. So I'll be basing my talk on these guidelines. Just before going into the specific organ management, we need to understand that what are the pathophysiological changes which take place after brain death. The hallmark is sympathetic storm, and it comes as a result of raised ICD, Cushing response, and progressive brainstem ischemia. Now once this sympathetic storm is there, the two organs which suffer the most, they are the respiratory system and the cardiovascular system. The cardiovascular system can present with reduced cardiac contractility, hypotension, bradycardia, arrhythmias, necrosis, and what is known as stress cardiomyopathy or Takotsubo cardiomyopathy. At the same time, the lungs are exposed to alveolar epithelial damage because of the oxidative stress and inflammatory response which is going on. The patient is intubated on mechanical ventilation, so the lungs suffer from ventilative stress. They undergo VLE, VALI, biotrauma, and at the same time there is increased capillary permeability, there is oxidative stress, and what we get is ultimately the lungs, which is something like an ARD slump. So you have to keep these things in the mind before you go to the management. Now coming to the specific organ management, as far as the hemodynamics are concerned, whatever goals have been set for these patients, they have been derived from case series, empiric protocols, and consensus conferences. Unfortunately, we do not have concrete evidence that what is the best hemodynamic management for these patients. They are all based on small randomized controlled trials and observational data. And there was one of the very interesting study, the protocolized fluid therapy in brain dead donors, the multicenter randomized monitor trial. This trial had to be abandoned in between. The reason was that it showed that protocolized care for these patients has no influence on the organ retrieval as compared to the conventional management which is done by the clinician at the bedside based on his skill, expertise and knowledge. As far as the vasoactive agents, because these patients suffer from vasoplasia and severe hypotension, there is no superiority of one regime over the other. Dopamine still remains one of the first-line agents for managing hypotension. Vasopressin is an alternative first line, or it can also be added for refractory shock. You can choose norepinephrine, phenylephrine, dobutamine, epinephrine, any vasopressor, depending upon your institutional policy, your guideline for managing shock. As far as the hemodynamics are concerned, the goal remains that you should always try to have an ejection fraction of more than 45%. And if still by the use of fluids, adequate resuscitation, use of vasopressors, if you are not able to maintain an adequate hemodynamics, then the hormonal replacement therapy also comes into picture, which is usually not used in other critical ill patients. Monitoring, there are no major studies to dictate that which type of monitoring should be applied for brain death tolerance. It can be based on the usual parameters, the parameters which are used routinely in all ICUs for all any other critical ill patients. You can use any of those modalities for hemodynamic assessment. As far as the cardiac function is concerned, transthoracic echo is considered to be the best. If there is some anatomical difficulty and you cannot perform a transthoracic echo, then you can go for transesophageal echocardiogram. So the recommendations for hemodynamic management are hypovolemia should not be allowed. It should be corrected by adequate fluid resuscitation. The target should be, like for any other patient, try to maintain a MAP of more than 60. Urine output should be at least 1 ml per kg per hour. In some patients, you can go as high as 3 ml per kg per hour. The ejection fraction, you should target a more than 45%. And if you have to use vasopressors to maintain the hemodynamics, then try to use the minimal possible dose of the vasopressor to limit the side effects and the adverse effects. As far as the initial volume displacement is concerned, you can choose crystalloids in the initial part. There is no harm. Choose isotonic saline. If possible, you can go for buffers. But colloids can come into picture if too much of IV crystalloids are needed because of there is too much of leak and causing too much of extravascular loss of fluid. Colloids are acceptable. You can use 4% albumin, 5% albumin, or 20% albumin. But as far as the colloids are concerned, starches are to be avoided. Respiratory management basically revolves under the physiological changes which take place in a brain dead patient. One is the neurogenic pulmonary edema. The other is the alveolar epithelial cell damage, leading to more leakage and more extravascular lung water, pulmonary edema and oxidative stress, and then there is a double hit which comes as a result of the cardiovascular components. The best strategy for managing these patients is like any other patient in ICU, and that is adopt a lung protective ventilation strategy. And this is one of the studies which was published in JAMA in 2010. The study was stopped prematurely because it was found that if you use lung protective ventilation in these patients who are there for organ donation, you are increasing the organ harvesting almost by 2 times. You are doubling the organ harvesting if the patients are subjected to lung protective ventilation. Now, what are the targets of the lung protective ventilation? Choose a low tidal volume, 6 to 8 ml per kg. PEEP should be used around 8 to 10 centimeters of water and plateau of less than 30 centimeters. And then there are some specific targets with respect to pH, the PaO2, saturation, and PCO2. Now, why I want to highlight about the PEEP and the tidal volume is that even if the patient had a normal lung, when they were subjected to lung transplant, it was found that there was a huge rate of rejection of those lungs which appeared to be normal, which was supposed to be normal. And retrospectively, they analyzed that these lungs could not be used for the patient for lung transplant because adequate recruitment maneuvers were not performed when they were being managed in the ICU settings. A lot of endocrine changes take place in the patients who suffer from brain death. And if you see into the list of the endocrine organs, you will find that almost every endocrine organ, they are subjected to subdysregulation. There is a failure of hypothalamic pituitary axis, there is impaired thyroid hormone secretions, there is hypoadrenalism, which also predisposes to cardiovascular collapse, and sometimes this patient will land up in complete vasoplasia and do not even respond to the vasopressors. There is decreased insulin secretion and the patients manifest with hyperglycemia. Diabetes insipidus is one of the most common endocrine dysfunction which is seen in these patients. There is a clinical diagnostic criteria which is based on the urine output, sodium level, serum osmolarity, and dilute urine. You can go into the details, these definitions are given everywhere. But the recommendations for managing diabetes insipidus, as far as the guidelines are concerned, is that if the patient is hypotensive and you have suspicion of low SVR, you should start arginine vasopressin. If the sodium is more than 145 to 150 and the patient does not have hypotension, then you can give desmopressin. You can use a combination of desmopressin and AVP if the patient is hemodynamically unstable and has severe hyponatremia. And when the patient has diabetes insipidus, pouring a lot of urine, then he has also a chance of suffering from hypokalemia, hypophosphatemia, and hypomagnesemia. And all these dyselectrolytemia should be looked for and adequately managed. As far as the other hormone replacement therapies are concerned, the corticosteroid replacement, all the trials, all the studies, they are neutral. They are neither in favor nor against. But it has got a strong physiological rationale to start steroids in these patients, because once a patient suffers a brain death, there is upregulation of the pro-inflammatory and the immunological mediators, which can cause immunological injury to the organs, and then you may have a poor harvesting. So that is why it is stressed that you can use steroids, and as far as the evidence is concerned, there is no strong concrete evidence to use it routinely for all patients. But if you want to use steroids, then it can be a methylprednisolone, high dose followed by an infusion. Thyroxine replacement. Now, thyroxine replacement, it has been seen, thyroid function tests have been done in brain dead patients, and they are not consistently low. Some patients have even shown normal to near high levels of thyroid hormone. So it is still not known what are the optimal thyroid hormone levels in these patients. And even if they have suffering from hypothyroidism, they might be suffering from sick thyroid syndrome, which is an entity which is seen in critically ill patients. And the recommendations are that you do not treat sick thyroid syndrome. But you can get some clinical benefits. They do come from observational data, and they suggest that if you do thyroxine replacement, you might get some benefit in cardiovascular optimization. You might get reduction in the vasopressors and anotropes, and you may get some hemodynamic stability. So the recommendations for the thyroxine replacement are, if the patient is especially for the cardiac transplantation, and you want to achieve an ejection fraction of more than 45%, you are adequately fluid resuscitated, you have already gone on too much of your vasopressors, and still you are not able to maintain the adequate hemodynamics. Glycemic control, like any other patient, you need to control the sugars. The rationale is that if the patient has been seen, if they are subjected to hyperglycemia, then the graft functions are not adequate in the post-transplant period. Yes, it should be managed according to your local guidelines, but the target should be try to keep a blood sugars of less than 180 mg/cent and use intravenous insulin continuous infusion, and dextrose containing fluids should be avoided at all costs. Nutrition, yes, the optimal feeding strategy is not clear. The guidelines recommend that give nutrition support to the brain dead person as it would not have occurred. Suppose he was like any other patient in the ICU. So he needs nutrition supplement just like any other patient, and it is always prudent not to start early parenteral nutrition for the bad effects which it contributes to metabolic derangements plus the chances of infections. Temperature dysregulation is inevitable. So you should try to keep a temperature above 35 degrees centigrade. There are a lot of physiological processes and pathological processes which are going on and contribute to hypothermia. And even if you go into the definition of brain death, you need to keep a temperature beyond 35 degrees centigrade. So you can use active warming, you can use passive warming, and if the patient is hemodynamically stable, it becomes all the more important reason to have a near normal body temperature. Anemia and coagulation, there are no recommendations at present from brain dead patients that what should be the hemoglobin levels and how you should treat coagulopathy, or what should be the levels of INRs and platelets, and should you give low molecular weight heparin thromboprophylaxis or not. There are no guidelines at present. But what the studies suggest and what the guidelines say is that treat these patients just like any other patient in ICU. So the trigger remains the same. If you want to transfuse fat cells, the trigger should be somewhere less than 7. Try to keep a hemoglobin between 7 to 9. If the patient is subjected for surgery, try to keep an INR of less than 1.5, a platelets of more than 50,000. And if you want to give DVT prophylaxis or low molecular weight heparin prophylaxis, suppose the time period for organ donation is organ retrieval is 24 hours or 48 hours, you can go ahead with low molecular weight heparin prophylaxis. Infection screening and management. Like any other patient, you have to take a detailed clinical history, you have to do a complete examination, and there are some infection screening protocols which may vary from institutes and hospitals, so you have to follow those protocols. And there are some infections which are endemic in some geographic areas, so you have to look after those infections. The reason being that if you transplant that organ and the patient was having those infections, then the chances of rejection are increased. But one thing which we need to understand here is that bacteremia, ongoing bacteremia or sepsis is not a contraindication to donation, provided we have given adequate and appropriate antibiotics for at least 48 hours. And if the infection is diagnosed once even the organ has been transplanted, then that infection should be immediately informed to the managing team to start appropriate antibiotic or antifungal therapy. So to conclude, the brain death induces a huge physiological response, mainly influencing the cardiovascular, the respiratory, and the endocrine systems. The hemodynamic and respiratory management is more or less the same like any other critically ill patient admitted in ICU. Specific endocrine therapies come for very specific patients, and especially for those patients where you have given adequate fluid resuscitation, you have started vasopressors, you have given inotropes, and still you are not able to maintain optimal hemodynamics, or you are not able to achieve your targets. Infection management remains a challenge because there is a chance of risk for transmission, so you should give adequate antibiotic or antifungal therapy to these patients. And the one thing which you need to remember is that whatever the elements are there, whatever the tenets of management protocols are there, which are still existing at present for the patients of brain death, they revolve around pathophysiological understanding, physiological rationale, and only on epidemiological observations. Unfortunately, we do not have any randomized trials to support that this therapy or this protocol is better for brain death patients. Thank you very much.